Now we will go for the subject. We invite Dr. Pramila to start the proceedings.
Seriously, biochemistry is the basis of inborn errors of metabolism, right? You all agree? So it's very important to diagnose inborn errors of metabolism early because we can prevent complications and we can improve the life of the child. So here, what is for any screening program, we prefer dry blood spot. What is the advantage of a dry blood spot? Because it can be transported at room temperature by courier. So what is the basic newborn screening panel? How many disorders are included in the basic newborn screening panel? 7 parameters are there. What are they? Hypothyroidism, congenital adrenal hyperplasia, G6PD, galactosemia, cystic fibrosis, PKU, and yes. So we have a program going on, NHM program, to prevent mental retardation. We are screening children with hypothyroid. We are screening for hypothyroidism, and I should thank Srinivasan sir for initiating that. And we have identified so many children, newborn children. Give him a big applause. So this is the blood sample for tandem mass spectrometry. So what are the disorders identified by tandem mass spectrometry? So tandem, on a single blood spot, we can identify around 40 disorders of urea cycle disorders, amino acid disorders, fatty acid oxidation disorders, and organic acidemias. So one drop of blood on a special filter paper, and that sample is for GCMS, for urine sample. So this is the processing of samples in our lab, in ICH Biochemistry Department. This is a collection of sample. What happens to the dry blood spot? So all these samples are collected on a special filter paper, and this is transported to the lab where we have a DBS puncher. It's an automated punching machine. It looks like a punching machine. So we just punch the samples, and you have seen ELISA wells. Have you seen ELISA wells? So just each spot is dropped into one ELISA well, and then buffer is added to make it into solution, and then it is processed by a tandem mass spectrometry. So this is the processing. And can you identify, we can identify around, on a single spot, we can identify 40 parameters. So here, valine and leucine are high. You can see the peaks there, the valine and leucine are high. So what is the disorder? Which disorder has valine and leucine high? Maple syrup urine disease, good. So organic acidemias. So these two disorders, methylmalonic acidemia and propionic acidemia, both present with the similar symptoms. Even the GALAC. What is GALAC? So that basic parameters, glucose, there's hypoglycemia. You can see the values here. There's hypoglycemia. Ammonia levels are high. Lactate, there's lactic acidosis. And ABG, there's metabolic acidosis with high anion gap. And there's ketosis. So what is the biochemical basis of this? Why is there hypoglycemia? And why is there hyperammonemia? What is the reason for that? We'll see it here. So this is a picture from Scriver. Have you read Scriver? Metabolic disorders, okay. So hyperammonemia is due to there's a block here. So due to increased organic acids, the propionic acid and methylmalonyl CoA is increased. You can see in the center. So because of organic acid accumulation, this inhibits the enzyme N-acetyl glutamate, the first step in urea cycle. What is NAG? NAG activates carbamyl phosphate synthase 1. So it inhibits this enzyme so that ammonia, there is hyperammonemia. Why is there hypoglycemia? Glucose levels are low. You can see at the extreme corner. Because these organic acids inhibit gluconeogenetic pathway. So it inhibits the pathway at two stages. One is conversion of pyruvate to oxaloacetate, the other one is malate shuttle. So because of this inhibition, there is hypoglycemia. And in addition, glycine levels are high. What is the reason for that? These organic acids inhibit glycine cleavage pathway. And lactic acidosis, because pyruvate has to be, so there is a block in the gluconeogenic pathway. So this is converted to lactate. So these are the biochemical basis of. What about ketosis? There is ketosis. What is the reason for ketosis? So normally acetyl-CoA combines with, this is the citric acid cycle. So acetyl-CoA, oxaloacetate combines with acetyl-CoA to form citrate. But when the propionyl-CoA level is high, so this competes with acetyl-CoA. So this combines with oxaloacetate to form methyl citrate, which accumulates in the blood and which is excreted in urine and is toxic. So because of this, acetyl-CoA enters the ketogenic pathway and ketosis occurs. Is it clear? So this is a tandem mass spectrometry report. So where in our lab we do 37 parameters. So here you can see propionyl, C3 propionyl carotene is increased. So what is your diagnosis when C3 propionyl CoA is increased? What is the disorder? It can be either propionic acidemia or methylmalonic acidemia, or it can be due to B12 deficiency. So in both these conditions, you can see, so propionyl CoA is intermediate in the metabolism of which amino acid? Valine, isoleucine, threonine and methionine and odd chain fatty acids. So propionyl CoA is the intermediate in the metabolism of all these amino acids. So it has 3 carbons, 3 carbon propionyl CoA. So this is converted to 4 carbon methylmalonyl CoA by the enzyme carboxylase. Which vitamin is needed for carboxylation reaction? Biotin. Good. So this 4 carbon methylmalonyl CoA is converted to succinyl CoA, and here you need, what is the coenzyme? Which vitamin is needed here? B12. B12 is needed. So when there is a block here, I am not able to use the pointer. Pointer where irka? Ida? How do you use this? Yes. So when there is a block here, when this enzyme is deficient, the enzyme which converts propionyl CoA to methylmalonyl CoA is deficient, what happens? C3. So propionyl CoA is 3 carbon compound. So C3, propionyl CoA combines with carnitine to form C3 carnitine. So this is elevated. And when there is a defect here, what should accumulate? Methylmalonyl CoA has 4 carbons. So this should accumulate, C4 should accumulate. But this reaction is reversible. So most of the accumulated C4 is converted to C3. So you get only C3 elevation on TMS. Are you able to follow? So when there is a block here, so conversion of propionyl CoA to methylmalonyl CoA, C3 levels are increased. And similarly, when there is a block here, C4 should be increased, but C4 is not increased. It is converted back to C3. So in both the conditions, C3 is increased. So on TMS you have seen C3 is increased, right? So how do you differentiate? So we cannot differentiate whether it is due to propionyl-CoA this enzyme deficiency or this enzyme. So further you have to do GCMS, urine GCMS. So what will you get? So when there is propionyl-CoA here deficiency here, all these are excreted, organic acids are excreted in urine. And when there is a defect here, along with this, you find methylmalonic acid excretion also. So this is how you differentiate. On TMS, C3 carnitine level is increased and you have to do GCMS to confirm. So along with this, if the block is here, only these three are excreted in urine. If the block is here, along with these three, methylmalonic acid is also increased. So by this you can confirm whether it is a block here or here. So if methylmalonic acid is also excreted, it's a block here. But this reaction, you need B12 in the form of adenosyl cobalamin, right? So how do you differentiate whether this is due to the mutase enzyme or B12? How do you differentiate here? You have to differentiate, right? So this is the metabolism of B12. B12 enters the cell into the lysosome and this is processed here. This is the common pathway and it splits, which enters the mitochondria. The other pathway is in the cytoplasm. So this pathway, so what are the two coenzymes of B12? Adenosyl cobalamin. The other one is methylcobalamin. Okay. So when there's a block here, what happens? So how do you find out whether it is because of mutase deficiency or B12 deficiency? How do you differentiate this? When you give B12, what happens? This is B12 non-responsive. When the block is due to mutase deficiency, B12, it is B12 non-responsive. If it is due to the adenosyl cobalamin, when you give B12, it is responsive. So, and one more condition, it's a combined condition. When there's a block here, it's a combined condition where you get methylmalonic acid excretion and homocystinuria. When there's a block here, when there's a block in the common pathway, because when there's a block here, both coenzymes are not formed. Adenosyl cobalamin and methylcobalamin are not formed. So in addition to this, you have to look for methionine levels and homocysteine levels. What will be the homocysteine level? Elevated. And methionine levels will be decreased. In addition, folate is necessary for this methylation. When there is folate trap, and so you get megaloblastic anemia. The patient presents with megaloblastic anemia. When there is megaloblastic anemia, the block is here. When the child presents with homocystinuria and megaloblastic anemia, you have to think that the block is here. If there is no megaloblastic anemia and B12 and folic acid level is normal and homocysteine methionine levels are normal, you have to think of a block here. This is how you differentiate the three types of methylmalonic acid. Are you able to follow? You want me to repeat it or you are able to follow? So urea cycle disorders. Again one more cycle. So in urea cycle disorders, there is hyperammonemia and urea levels are low. Urea levels are low. And there is increased glutamin and alanine because when there is hyperammonemia, so these amino acids act as buffers. So glutamate is converted to glutamin and pyruvate is converted to alanine. So there is increased level of both these amino acids. And because there is liver failure, there is mild increase in transaminases. So what are the enzymes of urea cycle? The first two reactions takes place in the mitochondria. This is inside the mitochondria, CPS and OTC. OTC is ornithine transcarbamylase. So the other three enzymes are present in the cytoplasm. What are the other three enzymes? What are the other three enzymes? Synthase, lyase and arginase. So all these are present outside. So GALAC. So what are the findings you get here? Blood glucose is usually normal. Ammonia levels are very much elevated. Lactate is normal. And ABG finding, what do you get? Because ammonia stimulates the respiratory center and you get respiratory alkalosis. Ketone bodies are negative. So how do you differentiate the proximal 2 disorders from the distal 3 disorders? So when there is a block here, it could be either of the 2 proximal enzymes. So there is decrease in citrulline levels. Citrulline levels, when there is a block here, there is decrease in citrulline levels and decrease in arginine levels. But how do you differentiate these 2 conditions? It could be either when citrulline levels, when there is a block here, citrulline levels are automatically decrease. So how do you differentiate when there is citrulline, low citrulline? So it could be either of this. So you have to do orotic acid. What is orotic acid? It is formed in which pathway? Pyrimidine synthesis, yes. So here this, when there is a block here, so carbamyl phosphate accumulates and this enters the cytoplasm into the pyrimidine pathway. What is the enzyme there? CPS2. Here it is CPS1 and there is CPS2. So when this enzyme is deficient, carbamyl phosphate increases. When this is deficient, there is no formation of carbamyl phosphate. So in OTC deficiency, there is excretion of orotic acid. And here there is no excretion, right? Next is citrullinemia. Citrullinemia is the next step. Here, it could be either citrullinemia type 1 or type 2. Type 1 is a block here and type 2 is block here, where here citrulline combines with aspartate to form arginosuccinate. When this enzyme is deficient, it is called citrullinemia type 1. When the transporter is defect, the mitochondrial transporter which transports aspartate into the cytoplasm needed for this reaction is deficient, it is called, what is the transporter here? Citrin is a transporter. When this is defective, it is called citrullinemia. In both these conditions, citrulline levels are very much high. Citrulline levels are very much increased. So next is a block here. When there is a block in the next step, so citrulline levels are increased but not as much as in citrullinemia, and this substrate is also increased. Arginosuccinate is also increased. When there is a block here, arginase is deficient. What accumulates? Arginine accumulates. There is increased arginine. And in this case, orotic acid is also increased. What is the reason for increased in orotic acid? When arginase is deficient, arginine is increased. Why is orotic acid increased? So this arginine inhibits the enzyme here. So this stimulates the enzyme NAG, so that carbamyl phosphate is increased and orotic acid is increased in the blood. What is triple H syndrome? So when there is a block here, the transporter which transports ornithine from the cytoplasm into the mitochondria. So what happens? Ornithine levels are increased. So hyperornithinemia, and then increased ammonia. What is homocitrullinemia? So because ornithine is not available here to combine with carbamyl phosphate, lysine combines with this to form homocitrulline instead of citrulline. So this is triple H syndrome. And this was a baby diagnosed here in our institute. So urea cycle disorders, like what is the plasma citrulline differentiates the proximal from the distal, and urine orotic acid differentiates CPS1 from OTC deficiency. Tyrosinemia. So type 1 is, what is type 1? Hepatorenal tyrosinemia, right? Type 1 is when the last enzyme of the catabolic pathway is defective, it is hepatorenal tyrosinemia. So why is there PT and APTT are prolonged? PT, APTT are prolonged, and vitamin D, phosphorus is decreased. What is the reason? Yes, renal tubular acidosis, yes. So when there is a block here, these two intermediates accumulate, which are toxic. These two intermediates are toxic to the liver and kidney. So this causes severe liver dysfunction. So because of the liver dysfunction, the coagulation abnormalities, elevated aminotransferases, and jaundice is present. And this causes mutations. These two intermediates cause mutations which can lead to hepatocellular carcinoma. So serum alpha fetoprotein is elevated, and these intermediates, they cause renal tubular dysfunction and cause Fanconi-like syndrome. So there is generalized amino acid excretion, aminoaciduria, and phosphate reabsorption is inhibited. So this will lead to hypophosphatemic rickets. And why is there methionine, increase in methionine? Hypermethonemia, which leads to cabbage-like odor. So this intermediate inhibits methyl, the enzyme which breaks down methionine. So methionine levels are elevated. And the important thing is succinyl acetone is formed from this, which inhibits the heme pathway. ALA is elevated. What is ALA? Aminolevulinic acid, and which is neurotoxic and causes peripheral neuropathy mimicking acute intermittent porphyria. So urine organic acids, what do you find in urine? So succinyl acetone is an important marker, and apart from that, these organic acids are also excreted in urine. What is the treatment for type 1 tyrosinemia? Nitisinone. Where does it act? It inhibits the second enzyme, right? Carnitine deficiency. So CPT1 deficiency affects only liver, which leads to hypoketotic hypoglycemia. So TMS, what do you find? Free carnitine levels are elevated. You know this pathway? You are aware of this pathway. So free carnitine levels are elevated, and the acyl carnitine levels are decreased. Whereas CPT2 and translocase deficiency, what is found here? It affects skeletal muscle, and it causes hypotonia and muscle weakness, and TMS finding is elevated long chain acyl carnitines. Medium chain, MCAD, what is MCAD? Medium chain acyl CoA dehydrogenase. So this enzyme helps in breakdown of fatty acids to acyl CoA, acetyl CoA. When the medium chain, what are medium chain fatty acids? 4 to 12 carbon fatty acids. So here these fatty acids are not broken down, which leads to hypoglycemia, non-ketotic hypoglycemia. Because of the block here, fatty acids cannot be converted to acetyl CoA, and from acetyl CoA ketone bodies cannot be formed. So there is non-ketotic hypoglycemia. Yes. So this is the last slide. So here, GALAC, what do you find here? Blood glucose is decreased. And what is the other parameter you find here? Ketone bodies are negative. That is the main thing you see here. Okay, thank you. And here, these are the disorders identified. All RPGs must be knowing. So 3 cases of glutaric acidemia. How do you identify a child with glutaric acidemia? Macrocephaly, yes. Which pathway is affected here? Which pathway is affected? Which amino acid? Lysine, hydroxylysine, tryptophan. So this, all these children are getting supplement, dietary supplement. Srinivasan sir has arranged for this. So we thank Srinivasan sir for all these children are getting. You can see the child here, isovaleric acidemia. This is a newborn child, and after 6 months, so the newborn child was identified by TMS, and the child was getting supplement. You can see the normal growth of the child, and here the PKU child. So we can improve the quality of life of the child. Hyperarginemia child, even this child is getting. So this is MICUD child, we diagnosed recently. So all these children are getting supplement. Thank you.